It's not just heartburn. 11 hiatal hernia signs you're probably ignoring. What if I told you that up to 60% of people over age 50 have a condition they don't even know exists, and you might be dismissing it as simple heartburn right now? Every year, millions of people reach for antacids, thinking they're dealing with ordinary acid reflux. But here's what's actually happening. Studies show that approximately 95% of people with hiatal hernias experience heartburn as their primary symptom, which means they're treating the smoke while ignoring the fire. A hiatal hernia occurs when part of your stomach pushes up through your diaphragm into your chest cavity. And while that might sound rare, research indicates it affects between 20 to 40% of the adult population in Western countries. But here's where it gets interesting, and probably why you clicked on this video. That burning sensation after meals isn't the only warning sign your body is sending. In fact, there are 11 distinct symptoms that most people never connect to this condition, and some of them have nothing to do with your digestive system at all. So if you've been telling yourself it's just heartburn or just stress, the next few minutes might completely change how you interpret what your body's been trying to tell you. Note, this video is for educational purposes only and not a substitute for professional medical advice. Always consult a qualified healthcare provider about your health. All information shared is backed by credible, peer-reviewed research with links to the original studies in the description. Let's start with sign 1, epigastric pain. When you feel pain right below your breastbone in the upper part of your abdomen, that's epigastric pain, and it might be your hiatal hernia talking. The epigastric region is the area just beneath your sternum where your stomach sits, and this pain often strikes during or after meals. According to research published in the Saudi Journal of Medical and Pharmaceutical Sciences in 2023, this type of pain frequently leads people to get an upper endoscopy, where doctors often discover a hiatal hernia lurking behind the symptoms. The pain happens because part of your stomach pushes up through the diaphragm. That's the muscular wall separating your chest from your abdomen. This herniation creates two problems simultaneously. Acid reflux irritates the delicate tissues, and the herniated stomach portion creates mechanical pressure. The Annals of Laparoscopic and Endoscopic Surgery documented in 2021 that this pain particularly affects people with large or paraesophageal hernias, where the stomach sits beside the esophagus rather than below it. What makes this pain distinctive is its relationship with eating and position. You might notice relief after vomiting, or reducing how much you eat, which temporarily decreases the pressure. The herniated stomach disrupts normal gastric emptying, the process of food moving from your stomach to your intestines, causing food to linger longer than it should. This localized inflammation creates a persistent discomfort that many people mistake for simple indigestion. The mechanical displacement alters how your stomach functions, creating a cascade of digestive issues. Understanding this specific pain pattern helps distinguish hiatal hernia from other digestive disorders that might cause similar symptoms, but require different treatment approaches. 2. Early satiety and bloating. Early satiety means feeling uncomfortably full after eating just a small amount of food. Imagine feeling stuffed after only a few bites of your favorite meal. This happens because the herniated portion of your stomach reduces its normal capacity and interferes with peristalsis, the wave-like muscle contractions that move food through your digestive system. The World Journal of Laparoscopic Surgery reported in 2023 that these symptoms result from the mechanical displacement caused by the hernia, essentially shrinking your stomach's functional space. Large type 4 hernias create particularly severe symptoms because the stomach can actually rotate inside the chest cavity. Sometimes other abdominal organs join the stomach in this upward migration, creating even more compression and blocking normal gastric outflow. This anatomical chaos explains why you might feel like you've eaten a feast when you've barely started your meal. The bloating sensation compounds the problem, making your abdomen feel distended and uncomfortable. Your stomach struggles to empty properly because the normal anatomical relationships that facilitate digestion are disrupted. The BMJ review from 2014 emphasized that when early satiety appears alongside nausea, it should raise immediate suspicion for hiatal hernia. These symptoms significantly impact daily life, forcing people to drastically modify their eating habits. Many patients report needing to eat multiple tiny meals throughout the day rather than normal portions. The severity of these symptoms often determines whether someone needs surgical intervention versus conservative management. The impaired gastric motility, your stomach's ability to move and process food, creates a vicious cycle. Food sits longer in the stomach, increasing pressure and worsening the herniation. Understanding this mechanism helps explain why dietary modifications alone sometimes fail to provide adequate relief for larger hernias. 3. Regurgitation. Regurgitation differs from vomiting because it happens effortlessly. Food or acid simply flows back up from your stomach into your throat or mouth without the forceful muscle contractions of vomiting. The Annals of Laparoscopic and Endoscopic Surgery documented in 2021 that regurgitation represents a hallmark symptom of GERD, occurring prominently in patients with sliding hiatal hernias. This symptom particularly disrupts sleep, as lying flat eliminates gravity's help in keeping stomach contents down. The anatomical disruption explains why regurgitation occurs so readily in hiatal hernia patients. The lower esophageal sphincter, which normally acts like a one-way valve between your esophagus and stomach, loses its proper pressure and positioning. Research published in the journal Life in 2024 revealed that the phrenoesophageal ligament, the tissue anchoring your esophagus to your diaphragm, weakens circumferentially, creating a perfect storm for retrograde flow. What makes regurgitation particularly frustrating is its resistance to standard acid-suppressing medications. The Cleveland Clinic Health Library noted in 2023 that while proton pump inhibitors reduce acid production, they can't fix the mechanical problem allowing stomach contents to flow backward. You might have less acidic regurgitation, but the food and liquids still come up. Type 1 sliding hernias and Type 3 mixed hernias show the highest rates of regurgitation symptoms. The sliding motion allows stomach contents to move more freely between the abdomen and chest. This explains why certain positions or activities trigger episodes: bending over, lying down, or any movement that changes pressure dynamics. Many patients describe the sensation as food getting stuck halfway down, then suddenly reversing direction. The taste of partially digested food or stomach acid becomes a constant companion. This symptom significantly impacts quality of life, affecting everything from food choices to social situations where unexpected regurgitation might occur. 4. Heartburn. Heartburn creates that familiar burning sensation rising from your stomach through your chest, but in hiatal hernia, it's amplified by specific anatomical changes. The gastroenterology report, published in 2024, found that nearly 1/5 of patients undergoing esophagogastroduodenoscopy for heartburn symptoms had confirmed hiatal hernias. The statistical analysis showed an odds ratio of 2.314, meaning people with heartburn are more than twice as likely to have a hiatal hernia compared to those without this symptom. The burning happens because your anti-reflux barrier fails on multiple levels simultaneously. Your lower esophageal sphincter separates from its normal position, and your diaphragmatic muscles can't provide their usual supporting squeeze. The BMJ review from 2014 explained that this double failure allows acidic gastric contents to bathe your esophageal lining, which lacks the protective mechanisms your stomach has against acid. Hernia size directly correlates with heartburn severity. Larger hernias create more frequent and intense burning sensations. The displaced anatomy increases both the volume of reflux and the time your esophagus stays exposed to acid. Life Journal's 2024 systematic review identified hiatal hernia as one of 3 primary drivers of GERD, with heartburn as its most distinguishing feature. The burning typically worsens after meals, especially with foods that relax the esophageal sphincter like chocolate, coffee, or fatty foods. Lying down or bending forward intensifies symptoms because these positions eliminate gravity's protective effect. Many patients describe the sensation as lava flowing upward through their chest. Unlike occasional heartburn from overeating, hiatal hernia-related heartburn shows a persistent pattern. It occurs regularly, responds incompletely to antacids, and progressively worsens without treatment. Understanding this distinction helps differentiate between simple acid reflux and the structural problem of hiatal hernia requiring more comprehensive management. 5. Dysphagia. Dysphagia, the medical term for difficulty swallowing, occurs in hiatal hernia through multiple mechanisms working against your normal swallowing process. The journal Dysphagia reported in 2024 that large paraesophageal hernias nearly double the rate of swallowing difficulties compared to control populations, with 6.1% versus 3.1% experiencing this troubling symptom. The herniated stomach compresses the esophagus from outside, while anatomical distortion disrupts the normal swallowing mechanism from within. The swallowing difficulty manifests differently depending on the hernia type and size. Some patients feel like food gets stuck behind their breastbone, while others experience a slow, uncomfortable passage of food into the stomach. Chronic inflammation from acid exposure creates additional swelling, narrowing the esophageal passage even more. The BMJ's 2014 review classified dysphagia as an alarm symptom requiring immediate investigation through upper endoscopy. This urgency exists because dysphagia might indicate serious complications, like esophageal stricture, a narrowing from scar tissue, or even malignancy. The mechanical disruption from the herniated mass affects the coordinated muscle contractions needed for normal swallowing. BMC Surgery's 2023 research highlighted that the impaired motility often requires surgical intervention when conservative measures fail. The herniated stomach creates a physical roadblock, while the displaced anatomy disrupts the pressure gradients necessary for efficient food transport. Patients often adapt by eating slowly, taking smaller bites, and drinking excessive fluids to wash food down. The symptom typically progresses from difficulty with solids to problems with liquids as the condition worsens. Many patients unconsciously modify their diet, avoiding meats, bread, and other foods that seem to stick. This progressive nature distinguishes hiatal hernia-related dysphagia from other swallowing disorders that might remain stable or improve with time.
6. Chronic cough. That nagging cough that won't go away might stem from your hiatal hernia rather than your lungs. The BMJ's 2014 comprehensive review explained that gastric contents refluxing through the failed esophageal barriers reach the upper airway, triggering protective cough reflexes. Large sliding hernias particularly disrupt both the lower esophageal sphincter and the diaphragmatic crua, the muscular opening where the esophagus passes through the diaphragm. The cough mechanism involves both direct irritation and neurological reflexes. When stomach acid reaches the upper esophagus and throat, it stimulates vagus nerve endings that trigger coughing. Additionally, microscopic amounts of refluxed material can enter the airways through microaspiration, causing direct bronchial irritation. Research published in the Annals of Laparoscopic and Endoscopic Surgery in 2021 and Medicine International in 2024 demonstrated significantly increased cough rates in hiatal hernia patients compared to healthy controls. The odds ratios from these studies support a direct causal relationship rather than coincidental association. The cough often worsens at night when lying flat maximizes reflux potential. The Journal of Thoracic Diseases 2016 clinical protocols emphasize that chronic cough unresponsive to acid-suppressive therapy should prompt evaluation for underlying hiatal hernia. This resistance to medication occurs because drugs reduce acid but don't prevent the mechanical reflux of stomach contents. The non-acidic reflux still triggers cough reflexes through volume and pressure effects. Many patients endure months of unsuccessful treatment for presumed respiratory conditions before discovering the true cause. The cough might be dry or produce clear phlegm from throat irritation rather than lung secretions. Understanding this extraesophageal manifestation helps explain why your respiratory symptoms might actually originate from your digestive system. 7. Chest pain. Non-cardiac chest pain from hiatal hernia can feel alarmingly similar to heart problems, causing understandable anxiety. The journal Surgical Endoscopy reported in 2020 that chest pain scores improved by 77% after hernia repair surgery, confirming the hernia's role in causing this symptom. The pain originates from esophageal irritation by refluxed acid and mechanical distension as the herniated stomach stretches surrounding tissues. The Annals of Laparoscopic and Endoscopic Surgery's 2021 review found that chest pain presents as the primary symptom in up to 25% of hiatal hernia patients without cardiac disease. This pain often radiates across the chest, sometimes into the back or arms, mimicking angina or heart attack symptoms. The similarity necessitates cardiac evaluation to rule out life-threatening conditions before attributing pain to the hernia. The Cleveland Clinic Health Library's 2023 publication identified specific triggers that distinguish hernia-related chest pain from cardiac pain. Activities increasing intra-abdominal pressure, eating large meals, bending forward, or lifting heavy objects typically worsen hernia pain. Cardiac pain, conversely, usually worsens with physical exertion and improves with rest. The pain mechanism involves both chemical and mechanical factors working simultaneously. Acid burns the esophageal lining, creating inflammation and spasm of the esophageal muscles. Meanwhile, the herniated stomach creates pressure against the diaphragm and surrounding structures, generating a squeezing or crushing sensation. Patients often describe the pain as burning, squeezing, or sharp, lasting anywhere from minutes to hours. Position changes might provide relief, unlike cardiac pain, which typically remains constant regardless of position. The pain might respond partially to antacids, offering a diagnostic clue, though this response isn't definitive since cardiac pain can occasionally improve with antacids through unclear mechanisms.
8. Laryngitis and hoarseness. Your voice changes and throat irritation might signal stomach acid reaching places it shouldn't, specifically your larynx or voice box. The Journal of Thoracic Diseases 2016 publication documented that hiatal hernia-induced GERD frequently causes laryngopharyngeal reflux, where stomach acid travels high enough to inflame the delicate laryngeal tissues. This creates chronic laryngitis, manifesting as persistent hoarseness, throat clearing, and voice fatigue. The laryngeal mucosa lacks the protective mechanisms present in the esophagus, making it extremely vulnerable to acid damage. Even small amounts of refluxed acid can cause significant inflammation, swelling the vocal cords and altering their vibration patterns. Surgical Endoscopy's 2020 review demonstrated remarkable improvement in hoarseness following hernia repair, with validated patient outcome measures confirming significant voice recovery. The systematic review in Life Journal from 2024 emphasized that these upper airway symptoms occur most frequently in patients with significant anatomical disruption from their hernia. The symptoms often develop gradually, with patients noticing progressive voice changes over months or years. Morning hoarseness is particularly common as nighttime reflux bathes the larynx in acid for hours. Singers, teachers, and others who rely on their voice professionally often notice these changes first. The voice might crack, fade with use, or develop a raspy quality that wasn't present before. Chronic throat clearing becomes a reflexive response to the sensation of mucus or irritation that never fully resolves. The inflammation can create a globus sensation, feeling like something's stuck in your throat. This phantom lump drives constant swallowing and throat clearing, further irritating already inflamed tissues. Many patients undergo extensive ENT evaluations before the connection to their hiatal hernia is recognized, highlighting how these symptoms can mislead both patients and physicians. 9. Asthma-like symptoms. Wheezing, shortness of breath, and bronchospasm from hiatal hernia can perfectly mimic asthma, leading to misdiagnosis and ineffective treatment. The Chinese Journal of Gastroesophageal Reflux Disease 2025 research revealed measurable pulmonary function impairment in hiatal hernia patients, with 41.8% experiencing uncontrolled asthma-like symptoms. These breathing difficulties arise through multiple pathways: microaspiration of refluxed material and vagus nerve-mediated reflex bronchoconstriction. When tiny droplets of stomach contents enter the airways, they trigger immediate protective responses, including bronchial constriction and mucus production. The vagus nerve creates another pathway, where esophageal acid exposure triggers reflex narrowing of the airways without any aspiration occurring. This dual mechanism explains why standard asthma medications might provide incomplete relief. The Annals of Laparoscopic and Endoscopic Surgery's 2021 findings and Life Journal's 2024 review both confirmed that hiatal hernia significantly worsens pre-existing asthma and can create asthma-like symptoms in previously healthy lungs. The relationship proves bidirectional. Asthma medications that relax smooth muscle might worsen reflux, while reflux triggers worsen asthma. This creates a challenging cycle requiring careful management of both conditions. Patients often notice symptoms worsen after meals, when lying down, or during activities that increase abdominal pressure. The breathing difficulties might include chest tightness, wheezing audible without a stethoscope, and exercise intolerance. Nighttime symptoms particularly suggest reflux-triggered bronchospasm, as the supine position maximizes reflux potential. Treatment-resistant or adult-onset asthma should raise suspicion for underlying hiatal hernia. Many patients undergo years of escalating asthma treatments without improvement because the root cause remains unaddressed. Understanding this connection explains why fixing the hernia might improve breathing more effectively than bronchodilators or inhaled steroids. 10. Iron deficiency anemia. Iron deficiency anemia represents one of hiatal hernia's most serious yet overlooked complications, particularly with large hernias. BMC Surgery's 2023 research found that 27.8% of massive hiatal hernia patients developed iron deficiency anemia, with surgical repair achieving over 93% resolution rates. The anemia results from Cameron lesions, linear erosions forming where the herniated stomach rubs against the diaphragmatic opening, causing chronic microscopic bleeding. These Cameron lesions develop from mechanical trauma as the stomach moves through the hiatal opening with breathing and swallowing. The constant friction creates superficial ulcerations that bleed slowly but persistently. The BMJ's 2014 review recommended considering large hiatal hernia as a direct cause for unexplained iron deficiency anemia, especially after ruling out other gastrointestinal bleeding sources. The blood loss typically remains invisible to the naked eye, making detection challenging without specific testing. Patients might notice progressive fatigue, weakness, pale skin, or shortness of breath from their declining hemoglobin levels. Some cases present dramatically with melena, black, tarry stools indicating digested blood, or even require emergency transfusions when acute bleeding occurs. Endoscopic evaluation commonly reveals these characteristic lesions at the herniation site, confirming the diagnosis. The lesions appear as linear red streaks or erosions, often multiple, located precisely where mechanical trauma occurs. Women and elderly patients face higher risk due to lower iron reserves and decreased ability to compensate for ongoing losses. The anemia might be the presenting symptom that leads to hernia discovery, particularly in patients with few digestive complaints. Regular monitoring of iron levels becomes essential for patients with known large hernias. Understanding this complication emphasizes why large hernias often require surgical intervention, even when other symptoms remain manageable with conservative treatment. 11. Belching. Excessive belching, the involuntary expulsion of gas through your mouth, frequently accompanies hiatal hernia, creating social embarrassment beyond physical discomfort. The BMJ's 2014 comprehensive review explained that anatomical disruption from the hernia increases aerophagia, unconscious air swallowing, while simultaneously disturbing normal gastric emptying. This dual problem creates a perfect storm for gas accumulation that must escape upward. The herniated stomach loses its normal anatomical relationships, affecting the complex mechanisms that usually prevent excessive air entry and facilitate normal gas passage. Patients unconsciously swallow more air while trying to relieve discomfort from other symptoms like chest pressure or throat irritation. The displaced stomach then struggles to move this air normally through the digestive system. Surgical Endoscopy's 2020 research demonstrated significant belching reduction after anatomical correction through hernia repair. The improvement in validated patient-reported outcomes confirmed that fixing the structural problem resolves the gas issues. Certain positions and activities worsen belching. Bending over compresses the herniated stomach, while eating increases both air swallowing and pressure within the displaced stomach. The belching often occurs in clusters, with patients experiencing repeated gas expulsions that provide only temporary relief. Many describe feeling air trapped in their chest, creating pressure that only resolves with belching. This differs from normal belching after carbonated beverages, as it happens regardless of diet and persists throughout the day. While belching alone doesn't definitively indicate hiatal hernia, its presence alongside other symptoms strengthens the diagnostic suspicion. Patients often modify their behavior, avoiding social dining or speaking engagements where unexpected belching might cause embarrassment. Understanding this symptom's mechanical basis helps explain why dietary changes alone rarely eliminate the problem completely.